All right, guys. So this week we were talking about wrist sprains and strains. So the guidelines would call that wrist pain or wrist stability with movement coordination impairments. When you look at the pain pattern, lots of times wrist sprains will look a lot like that. Of course, there's a lot of different structures that could be sprained or strained. And so you would basically, depending on where the pain location was, begin to have some hypothesis about what structures might be the source of the patient's symptoms. So here is sprain of carpal ligaments. You certainly could have a TFCC type of problem, distal radial ulnar problem. And then you could also, over time, with instability of the wrist, end up with wrist osteoarthritis. Okay, but here with sprain of carpal ligaments, when you look at the prevalence, you can see that this is a pretty common occurrence in highly trained athletes. Okay. When you look at the clinical findings, you'll be able to see someone, an athlete, talking about her problem.
Snowboarding up in Big Bear, I fell, landed right on my hand. It's starting to hurt to move in different directions, to put any weight on it. I can't do that at all. All around it, it's a little bit swollen as well.
Okay, so you get to watch a common occurrence, a common mechanism of injury. Of course, sprains and strains can occur with overuse as well. And you can look at the history, the reported findings, and the examination findings. So let's get into the physical exam. In the physical exam, we would typically, you could watch a key findings video, clinical reasoning video. There's a history of a fall on outstretched hand. Often forceful gripping or overuse could be related to the problem. And you would look at range of motion, right? So one of the key things that we do is assess whether range of motion is affected, look at accessory mobility, and use some special tests to assess for significant instability. Okay, so you can see these different ballottement tests, lunotriquetral, basically accessory mobility, the Watson scaphoid test, looking for a clunk, if the scapholunate ligament is torn, and then assessment of the intercarpal ligaments via accessory mobility gliding, dorsal and volar gliding. It's relevant also with many of your wrist and hand problems to take a functional measure, so your pain-free grip strength would be a good one to do. If we look at the movement faults, the movement fault typically is some type of history of trauma or overuse. And you never know, it might be relevant as you are asking them to test their grip strength to look at any other contributions. When you see this video here, you'll note a number of different corrections: thoracic spine, head forward position, humeral head position, and assessing whether the grip strength changes just to see if there's any other contributors to the patient's dysfunction. Here are some common associated impairments. The patient may have swelling, so you can assess that, and you may do some proprioceptive and kinesthetic testing. For your differential diagnosis, you really want to make sure that you clear the cervical, shoulder, and elbow, right? Because a lot of the jamming force that comes from falling on an outstretched hand can also cause dysfunction at these other joints more proximally. And you want to rule out scaphoid fracture, which is the 70% of the common wrist fractures. So your anatomic snuff box palpation, and then you may want to rule out median nerve involvement, which you see down here. All right, we're done with the physical exam. How would I treat this patient? In general, when it comes to subacute mobility, you may consider you need to restore mobility of the wrist and thumb and hand. You see a number of mobilization with movements, right? Some passive range of motion stretching. Now notice that we've labeled this as subacute mobility because in the acute phase, typically we would be using our modalities and putting the tissue that is affected in a neutral wrist splint, using ice, getting the tissue to calm down, immobilizing it, and then restoring mobility later. Right, here's your subacute mobility restoration. And then therapeutic exercises, of course, you can do mobility, restoring mobility, different exercises, wrist active range of motion with high repetitions, and movement coordination. In the early phases when the patient's quite painful, you might consider wrist isometrics, gentle submaximal isometrics. You will note if they are proprioceptive or kinesthetic impairments that you're going to use treatments that will help to restore these impairments. And then here's some subacute strengthening, different exercises to improve the strength of the wrist and hand. Ultimately, it is very important not to forget patient education. Remember to help them understand what's going on, how long it's going to take, what we are going to do in physical therapy, and how they can help themselves. Remember, they need to rest this tissue, which is largely why you're putting them in the splint initially. Okay, so that's it for wrist stability and movement coordination impairments, and hope you guys find that useful. You can check all of these out and more patterns at PhysioU, and they have a web app, iOS, and Android apps available for you to enhance your clinical reasoning.